Hello and welcome to our video on how best to care for patients with decompensated liver cirrhosis using the BSG Cirrhosis Care Bundle as a guide. I am Dr. Jamie Willows.
And I'm Dr. Alice Wheatley.
And I'm Dr. Simon Cowland, consultant gastroenterologist.
Over the next 15 minutes, we hope to remind you that decompensated liver cirrhosis is a common medical emergency which frequently presents to admissions units, and to introduce you to the Decompensated Cirrhosis Care Bundle as a useful guide to the management of these patients, which can be found on the BSG, the British Society of Gastroenterology, website.
What we know so far is that the management of patients with decompensated cirrhosis has historically been suboptimal, both on a national and a regional scale. There is evolving evidence that guideline-based management of these complicated patients improves care. Also, that early intervention during the patient's admission is critical to maximising their chances of a good outcome.
This video is aimed at all members of the clinical team who encounter patients with liver cirrhosis in their daily practice, be it admitting junior doctors, senior doctors, nurses or nurse practitioners. So let's recap what decompensated cirrhosis means. Decompensation is essentially a deterioration in liver function. Decompensation can manifest in a number of ways, including jaundice, increasing ascites, hepatic encephalopathy, renal impairment or hypovolemia, signs of sepsis.
We can determine whether a patient has a diagnosis of cirrhosis through review of their old notes, previous clinic letters, or by review of historical imaging reports. However, you may be the first person to pick up a potential diagnosis of cirrhosis, and this can be elicited by 1. Assessing risk, with obviously alcohol excess being one very common risk factor. 2. Examination findings, namely the stigmata of chronic liver disease indicative of portal hypertension, such as spider nevi or ascites. Or 3. Through review of blood tests, namely low platelets, high PT, high bilirubin, low albumin, or deranged liver enzymes.
However, decompensated liver cirrhosis is never the only diagnosis to make. You need to consider the cause for the decompensation. Common and serious causes we should consider on assessment at front of house include GI bleeding, renal impairment, and infection, such as spontaneous bacterial peritonitis, the management of which will be covered later in this presentation. Other causes may be elicited from the patient's history, for example, any new medication, recent alcohol binges, or constipation. Some causes may be picked up by investigation back of house, such as a portal vein thrombosis or an HCC diagnosed on ultrasound.
The Decompensated Cirrhosis Care Bundle arose after a national inquiry in 2013 which reviewed the care of patients with cirrhosis. This indicated that less than 50% of patients received what they called good care. Similar results were found at a regional level where we work in the northeast of England. An audit of over 100 patients in 2013 showed that 1/5 of patients with variceal bleeding didn't receive terlipressin. Almost 2/5 of patients did not receive an acidic tap, despite being at risk of spontaneous bacterial peritonitis. And over a quarter of patients with AKI did not have high-risk medications like diuretics and ACE inhibitors stopped.
To improve care, the Cirrhosis Bundle was produced. The BSG and indeed the British Society for the Study of the Liver recommended that the bundle is used as soon as possible during a patient's admission, in patients with known or suspected liver cirrhosis of any cause. The bundle acts as a prompt to ensure everything required has been considered for your patient. It can be found on the BSG website entitled Decompensated Cirrhosis Care Bundle, first 24 hours. A quick internet search will bring it straight up, or your trust may have a version on their intranet page. If not, why not get the project going?
Firstly, it highlights the investigations that patients with liver decompensation are likely to need, both to investigate the severity of the decompensation and screen for its cause. for example, renal impairment, electrolyte disturbance, bleeding, or sepsis. As a rule of thumb, we recommend that the admitting team requests an ultrasound scan at an early stage to screen for portal vein thrombosis or hepatocellular carcinoma. The results can then be chased up back of house.
Please note that a repeat liver screen with tests such as ferritin and ceruloplasmin is not required in a patient with known cirrhosis.
In addition, testing ammonia levels is not required in the context of chronic liver failure, as hepatic encephalopathy is a clinical diagnosis, and ammonia levels do not correlate well with the severity of encephalopathy. This also saves you having to find some ice to put the test in. Remember, ammonia levels are only helpful in acute liver failure for prognostication, not decompensation of chronic liver failure. Next, an alcohol history is taken. Although not mentioned in the bundle, it should include when the patient had their last drink and whether they have had alcohol withdrawal seizures in the past. If a patient still drinks alcohol to excess, do not forget to give Pabernex, as this helps to prevent the life-changing condition of Korsakoff syndrome. The bundle also reminds the team to perform a symptom-based assessment of alcohol withdrawal, for example using the Clinical Institute of Withdrawal Assessment for Alcohol, or CIWA tool. This can then be used to guide the prescribing of chlordiazepoxide. If your hospital has an alcohol liaison service, remember that contacting them for patient support can also be invaluable.
The next section is further prompting for investigating infection and sepsis. This is of great importance due to the fact that patients with liver cirrhosis are at high risk of bacterial infections as a result of their low immune status. Infection and sepsis is the leading cause of death in these patients. Patients with liver cirrhosis commonly present with infections at the usual sites: urine, lung, biliary. However, they may not show classical biochemical signs of sepsis, such as raised white count, or the physical signs such as pyrexia as a result of their immunosuppression. Due to liver dysfunction, patients may not have significantly raised CRP and infection. Importantly, we also need to think about spontaneous bacterial peritonitis, SBP.
SBP is the presence of bacteria in the acidic fluid without a secondary reason for them being there, such as bowel perforation. It may present with the features of abdominal pain, fever, or encephalopathy. However, it is asymptomatic in roughly 1/3 of cases. The only indicator for SBP in these asymptomatic patients is the non-specific deterioration in liver function seen biochemically and on examination. We would recommend performing an acidic tap to screen for SBP as early as possible in the admission, ideally in the emergency department. The risk-benefit ratio of having an acidic tap is such that the BSG recommends it should be performed whatever the platelet count or prothrombin time.
The advantages of an acidic tap at an early stage are that it increases the likelihood of detecting an organism in the acidic fluid, can avoid delays in starting the correct antibiotic and albumin solution, so reducing mortality. Proving a diagnosis of SBP is better practice than just covering for it. Remember, a formal diagnosis of SBP is an indication for prophylactic long-term antibiotics and sometimes an indication to refer for transplant assessment. Antibiotic stewardship means that we should try hard to use antibiotics only where clinically indicated. The earlier we obtain the acidic fluid, the better it is for the patient. So, if you're not confident in performing a diagnostic tap, please discuss it with your senior. The bundle reminds you that the patient is treated for SBP if the neutrophil count in their acidic fluid is greater than 250 millimeters cubed, with IV antibiotics and also IV albumin.
The bundle then discusses what should be done in the context of an acute kidney injury. 3 common misconceptions here include:
1. Crystalloids will worsen ascites. Never give them.
Actually, these patients need to be fluid resuscitated just as you would resuscitate any patient with pre-renal AKI. The larger risk is that they won't get the intravascular hypovolemia treated adequately, and front of house it is reasonable to consider either crystalloid or IV albumin for volume expansion.
2. Okay, well I think the best fluid choice then is 5% dextrose to avoid all these problems.
Probably not. Hyponatremia is very common in decompensated liver failure, and that will only worsen the situation. Giving IV albumin and reassessing with repeat bloods is most important here.
3. Well, if you're going to give them fluid for the AKI, at least let me continue their diuretics for their ascites.
No! As with other patients with AKI, they need to have their diuretics stopped to address the more important clinical need.
The next section looks at GI bleeding as a cause for decompensation and how to manage it. Given the high mortality of untreated GI bleeds in these patients, the key points are to suspect bleeding and to treat as if there has been a variceal bleed if there's any compelling clinical evidence to support this. Though not specifically mentioned in the bundle, remember you should have a very low threshold for a PR exam in this population. The bundle reminds us that terlipressin should be given, as this is an effective treatment in decreasing blood loss from varices, though caution should be used in all patients with ischemic heart disease or peripheral vascular disease and over 65 years old due to risk of ischemia, and patients should first have an ECG. In addition, prophylactic IV antibiotics are given, a practice with a very strong evidence base to decrease mortality, rebleeding, and length of stay. The bundle then highlights discussion with specialties, namely gastroenterology to consider early OGD after resuscitation, and haematology if their blood abnormalities warrant further correction beyond IV vitamin K with products like FFP or platelets.
Next, the bundle asks you to consider exacerbation of chronic encephalopathy. In terms of the treatment and prophylaxis of encephalopathy, the bundle advises the use of lactulose as a very safe and effective first-line drug. It also encourages us to consider causes for confusion other than chronic encephalopathy. As we know this patient group has a high falls and bleeding risk, you may need to suspect diagnoses like subdural hematoma.
Risk of venous thromboembolism is considered next. It is an area filled with myths and misconceptions.
The high PT means they shouldn't give dalteparin, right?
Don't they auto-anticoagulate?
No. Let's take a minute to get this right. Studies suggest that you cannot predict the patient's bleeding risk in liver cirrhosis from the prothrombin time. Whilst the high PT tells you that the liver synthetic function is poor and not producing enough clotting factors, what you don't see is that the cirrhotic patient is not metabolizing clotting factors or producing anti-clotting factors. This shifts the balance in decompensated cirrhotic patients towards being prothrombotic and actually having a higher risk of venous thrombus embolism. So, to reduce the risk of DVT or portal vein thrombosis, the bundle recommends that these patients receive the usual prophylactic low molecular weight heparin as long as their platelet count is over 50 and bleeding is not suspected. Finally, the bundle then finishes with a reminder to hand over the patients to the gastroenterology team.
So to recap, national and regional data has suggested suboptimal management of this patient group. 1/5 of patients with variceal bleeding didn't receive telepressin. 40% of patients didn't receive an acidic tap despite being at risk of SBP, and over a quarter of AKI patients did not have nephrotoxics stopped.
We believe we should be providing better management than this, and that using the Cirrhosis Care Bundle is a way to help us to give the care these patients need.
To conclude, working in emergency departments and front of house, you will see decompensated liver disease. There is a lot to remember to do when managing these patients.
The bundle can be found on the BSG website. We would encourage trusts to incorporate the bundle into their own policies and guidelines in order to improve patient management. Remember, it is your early interventions at the beginning of the admission that are critical.
So, I have been Dr. Jamie Willows.
I have been Dr. Alice Wiedner.
And I've been Dr. Simon Cowler. Please get in touch by email if you have any questions or would like further information. Thanks for watching.